we've got some guidelines. You said there was a partial update to the guidelines, but there's going to be a full guideline update sometime this year. Is that right?
That's correct.
When do we expect that?
I would hope in the next several months it should. Right now it's under peer review process, so and that can take some time, depending on the number of peer reviewers and the number of comments that they have. Currently, what should be out in the next month or two are the AHA scientific statement biomarkers in heart failure, and so.
What does that mean?
Basically, it's a focus on the role of biomarkers in the assessment, the prevention, and management of heart failure. So it encompasses quite a bit, and also it's going to have some recommendations there and some considerations which are going to be matched with what the guidelines, the full guidelines, will provide.
But I just heard that some of the medications, the ARNIs, that we're prescribing are going to mess up the biomarkers.
Yeah, you know, my perspective might be a little different from Scott's, where I don't believe you should necessarily switch. If you're in an ARNI and you're in a hospital that uses BMP, what do we know about BMP? Well, we know that at 1 month you might get a bump of 20% off that BMP. That's showing efficacy. So I think in some ways it's more valuable. At 1 month over the 8-month period, you're going to see a drop, and so why not use that, a new measurement at the 1 month period as a new baseline, and then follow it out from there.
So you're saying that you start the ARNIs, you'll see a spike, that as the ARNIs become effective and the heart failure gets better, they go down because the heart failure is improving?
Correct.
Is that what you're saying?
So at that point, it would be a measurement of improvement of heart failure. You've created a new baseline. So that's one way to try to adjust for using BNP in your institution.
Well, Cheryl's right in that BNP does eventually go down if heart failure gets better, but it's going to be very confusing, I think, for practitioners. But the real question is, how often should we be using these guidelines, these biomarkers anyway? Should we be following them? Should we use them to decide what patients to give the drugs to? If they don't go down, do we stop giving the patients drugs? I think there's a lot of questions here that we haven't yet answered. And I'm not sure what I certainly don't know what the guidelines are going to say about this, but I think we have to be very careful to look at biomarkers alone and without paying attention to all the other things that we've been talking about.
What I heard was the biomarkers can often help break a tie or tip you one way or the other, but more often than not, they're not going to make the diagnosis for you. The diagnosis is made by history, physical, echo, whatever markers you've got. So it's fascinating. Resetting the baseline is interesting, but it may not be the be-all and the end-all. Is that what you're saying?
Yeah.
All right.
Absolutely.
Now, looking forward again, looking into the future, there are other models, other programs being looked at to improve heart failure prevention, right? Now, heart failure prevention, as far as I know, in the traditional model is eat better, exercise better, pick your parents better so that your LDLs are okay, or for gosh sakes, get them down. What else is there?
Well, I think there's two kinds of prevention. There's primary prevention, which is what we were talking about before, where you prevent the first episode of heart failure from ever happening, and that's hypertension control, coronary disease prevention. And then there's secondary prevention. You've had heart failure, and now you don't want to have it again. You don't want to end up back in the hospital. And there, I think there are a lot of strategies which fit broadly under the rubric of heart failure disease management. And those are the longitudinal programs, heavily nurse and pharmacist driven, that are regular surveillance of heart failure patients to re-emphasize the educational messages, the self-management messages, and the medication adherence messages that we started in the hospital.
So this is, again, as we were talking about before, getting them in the system, making sure the system doesn't forget about them, and bringing them back in to be sure there's compliance going on.
Yeah, it's not a one-off.
All right. And how does that impact readmissions reduction? Or is that a part and parcel of the same thing?
Well, I think within that scope, there are a lot of different strategies that have been employed. So one of them is regular inpatient clinic follow-up, but there are other strategies, including remote monitoring. So although telemonitoring of weights and vital signs hasn't routinely shown impact on readmissions prevention, it is an adjunct to care, and a lot of programs do it. There are other novel monitoring strategies that are under exploration, including serial measurement of natriuretic peptides and other measures of impedance or filling pressures even. And then there are strategies for what to do when the patient gets in trouble. So if the patient is symptomatic, one strategy is to send them to the emergency department, in which case they usually get admitted. But another strategy is to try and treat them in the outpatient setting with intravenous diuretics in, say, a clinic or an observation unit. And those strategies are drawing attention. And even at home, with some more innovative visiting nurse agencies, we can now deliver diuretics in the patient's home environment. And that's a way of preventing them from having to come to the hospital.